All right, continuing on our subject of sexually transmitted infections, let's now talk about chancroids. So chancroids are caused by Haemophilus ducreyi. So this is in the same genus as Haemophilus influenzae. So this is a gram-negative coccobacillus. So these are very short little rods, and they're pink colored in a gram stain. These are very, very fastidious in general. So these are catalase negative, oxidase positive, and they are usually grown on chocolate agar. Because to grow, they require so-called factor X, which is in, and that is contained in chocolate agar. The organism grows in a CO2-rich environment. So it needs a chocolate agar, CO2-rich environment. It'll form these small, gray, translucent colonies on plates. So it enters the body through skin breaks that occur during sexual intercourse. Enters the body through skin breaks. It has several virulence factors. First, it has a capsule. That capsule is antiphagocytic. That'll protect it from PMNs and things like that. It also has several different types of fimbriae. And these are adhesins. So it'll attach to fibroblasts and what have you. Also makes lipo-oligosaccharide. That also functions as an adhesin. When it attaches, it will recruit plenty of neutrophils and macrophages. But the organism makes a copper-zinc superoxide dismutase that protects it from the reactive oxygen species made by these cells. So these cells don't clear the organism though, because it deals pretty successfully with the reactive oxygen species. Then the organism makes two toxins. So there's the Haemophilus ducreyi cytolethal distending toxin. This is abbreviated HD, CTD. This causes cells to arrest their cell cycle. So it causes cell cycle arrest. Then it also makes a cytotoxic hemolysin. This will cause lysis of T cells, B cells, and macrophages. So these toxins will make cause a good deal of tissue damage. It then also has a zinc scavenging protein. Steals zinc from infected tissues. This will lead to injury of the epithelial cells and the fibroblasts. You therefore get disorganization of the epidermis. You get erythematous papules. That will appear. These are red raised elevations of the skin. These papules will accumulate pus, and they will burst, and they'll become painful ulcers. So these are very different than what you see with syphilis. So you get soft, irregular margins, and they are called soft chancres. Hence the term chancroids. Chancroids. So risk factors. Are having multiple sex partners. And having unprotected sex. Commonly you'll get lesions where tissues make contact. Lesions rather where adjacent tissues make contact. Those are called sometimes king ulcers. So for example, this is black and white, it's a little harder to see, but here's an ulcer on the prepuce, or the glans of the penis, and you can see these two tissues where one abuts the other. That's essentially where the lesion will form. Likewise in a female, as you can see here, you have the labia, the vaginal introitus, or the perianal area. You can see these various lesions here. Women may have symptoms that include dysuria, dyspareunia, there may also be abnormal vaginal discharge, and if there are cases where the anus is infected due to the use of anal sex, they also have rectal bleeding. Or painful defecation. %50 of the time, you might also have lymphadenopathy. That may also be painful. So chancroids diagnosed usually on the basis of the ulcers and adenopathy. You can grow the organism from an ulcer or an aspirate from the lymph node. There are also PCR tests that are available, and it's usually treated with a single dose of azithromycin or ceftriaxone. Or you can also treat it with multiple dose therapy of ciprofloxacin. The 500 milligrams, and that'll be twice a day. Usually you want to treat about 10 days with Cipro. Those are chancroids. I'd like now to talk about a relatively rare STI in the U.S., but you see this more overseas, and you'll see this also in immigrants. So it's called granuloma inguinale. Probably the more common term for it is Donovanosis. So in North America, this is relatively rare. But you see it pretty common in India, in Brazil, the Caribbean. Southern Africa. Let's see, where else do you see it? Oh, Australia. More than you would in North America. And then Papua New Guinea. Those are the places where you'd see it. It's caused by Klebsiella granulomatis. So this is a STI. Again, not usually common, but if you see it, you'll see it in immigrants usually. So the usually 1 to 12 weeks, that's the incubation period. After about 1 to 12 weeks, you'll get painless, red skin nodules. Those painless red skin nodules will then become raised, beefy, red, moist, smooth, and foul-smelling lesions. This lesion will enlarge, and it usually ulcerate and then spread to other skin areas. The lesions will heal slowly and with scarring. So these will enlarge, ulcerate, heal slowly with scarring. You can get secondary infections to other parts of the body. Very rarely you get spread to the bloodstream, to the bones, the joints, the liver. Without treatment, you get anemia, wasting, very uncommonly death. Most common sites of infection would be the penis, scrotum, and the thighs. That'd be the case in men. Females would be the vulva, birth canal, and the perineum. That'd be the case in women. If you have people engaging in anal, receptive intercourse, then the anus and buttocks, and then also in both sexes, usually have lesions also on the face. These ulcers can be secondarily infected with other bacteria. So usually the diagnosis is clinical, but you confirm it by doing scrapings of the lesions. And if you do, you'll have numerous bacilli in the cytoplasm of macrophages as revealed by either a Giemsa stain or even a Wright stain. And these bacilli, these are referred to as Donovan bodies, hence the name Donovanosis. The smears will also contain plasma cells. These bacteria don't grow on ordinary culture media. You have to grow them on chocolate agar. So fortunately, the organism is very treatable. So you can treat them with doxycycline. You're going to treat for 3 weeks. You can also treat with trimethoprim sulfamethoxazole twice a day, also for 3 weeks. Erythromycin has been used. And you use 500 mg 4 times a day, also for 3 weeks. And please remember, when you are treating an STI, make sure that all sex partners are treated. If you don't, people are just going to come back into your clinic reinfected. So make sure all sex partners are treated. That may require you to have some very uncomfortable conversations with your patients, but has to be done. And typically, you, the nurse, might be the one to do it. So get out of your shell and have those tough conversations with people. They will thank you for it. All right, we've talked about bacterial STIs. Let's now talk about some viral STIs. So there is herpes simplex virus 1 and 2. So one will usually infect above the waist. 2 will usually infect below the waist. So if someone has genital herpes, pretty safe bet they have HSV2, but there is overlap. So will that affect your treatment? Not necessarily, but just keep in mind, while this is the case most of the time, well, someone who has blisters on their gums or lip or something usually will have HSV1. There can be crossover. So that's something to keep in mind. Okay, so in a genital type of herpes, you have painful vesicles. And these painful vesicles have an erythematous base. So there will be pruritus in the genital area. There'll also usually be dysuria, and usually also inguinal lymphadenopathy. If there are systemic symptoms, then you usually have fever, headache, and myalgias, or so-called muscle aches. If the individual has antibodies due to a prior infection, then the symptoms are almost always less severe. And HSV can linger in the neurons. It can reactivate from time to time. Depending on the type of sexual intercourse, it can also, if you have anal sex, you can also have a proctitis, which will present with tenesmus, and also anal rectal pain. For diagnosis, you can do a viral culture. Not a whole lot of labs are set up for that, but usually there's HSV PCR tests, which you can get from these vesicles. There's also very good serology tests that will detect IgG to HSV. So treatment, will usually include drugs like acyclovir, famciclovir, penciclovir, or valacyclovir. Acyclovir comes as either an oral or a topical product. It can also be given intravenously under severe cases. Both famciclovir and valacyclovir are only available as tablets. And penciclovir is only available topically. These particular drugs, they interfere with the DNA synthesis of the virus. They're modified by the viral kinase. They act as guanosine analogs once they're phosphorylated. So they're phosphorylated by thymidine kinase. And then when the virus tries to incorporate them into viral DNA, you get termination of viral DNA synthesis. So they're specific for the virus, and they do a good job of stopping the growth of the virus and allowing healing. All right, so if you have a first episode, your first episode usually you're going to treat for 7 to 10 days. And you can use acyclovir. You'll do 400 mg 3 times a day. Valacyclovir. This is a prodrug form of acyclovir. That will be 1 gram twice a day. And then famciclovir, which is a prodrug of penciclovir. And this is given at 250 milligrams. Three times a day. The cream, if you're using the cream, you are going to apply it 6 times a day for 7 days. If you're using the cream on your lip for recurrent herpes labialis, then you use it 5 times a day for 4 days. So this would be the case for genital. This would be the case for labial. Recurrent infections are treated differently. You don't treat for as long. So in recurrent infections, you're going to use the same dose, also 3 times a day, but you're only going to treat for 5 days. Using valacyclovir for recurrent infections, it's going to be 500 milligrams BID, but only for 3 days. If you use a gram, you treat once a day for 5 days. Using famciclovir for recurrent, then use a gram once a day. And that's a one-shot deal. If you're trying to suppress an infection that's already in progress, then you'll simply use acyclovir 400 mg, but just twice a day, famciclovir 500 mg twice a day, and the valacyclovir just 1 gram. Those should knock it down. Now, if you have HSV encephalitis, which usually happens in children, then in that case you use intravenous acyclovir. And you have to treat, so every 8 hours, so it'll be TID, and for 21 days. And this will be 10 mg per kilogram body weight. And that is how you treat HSV. Very good. Our final topic is the subject of genital warts. These, of course, are caused by human papillomavirus. And so this is HPV. Strains 16, 18, 52, and 56. These are all associated with largely cervical cancer. Some will cause more benign lesions, like strain 6 and 11. These will cause warts in both the genital and anal area. And these so-called anogenital warts these are called condylomata acuminata. These warts can come in groups. They can have different shapes. They can be dome-shaped, plaque-like. They can have little stalks, pedunculated. They can be lobulated. They can be white, skin-colored, erythematous. If there is any uncertainty about the warts, they should be biopsied. There are very, very good serological and DNA tests for these. Nucleic acid amplification tests and serology. For these are the ones that normally the lab will send for. These can be done pretty quickly too. So to get rid of the warts, there's topical administration of imiquimod. Imiquimod, or these other things called cyanocatechins. Cyanocatechins, and these will burn the warts essentially. You can also treat them with trichloroacetic acid. If the lesions persist, you can use surgical excision, electrosurgery, cryotherapy, or you can treat them with trichloroacetic acid. Best way, of course, to assay for issues with the cervix, of course, is with a so-called pap smear. They're unpleasant, but women should really have them on a regular basis. And then finally, It's not specifically speaking an STI, but cytomegalovirus can be passed by sexual contact. It can be passed by kissing or intimate or even sexual contact. And this can be transmitted also vertically. So mother can transmit it to her baby. You can get it also from blood products. Transfusions, that's not as common these days because transfusions are screened so well. You can also get it from organ or even stem cell transplants. Again, screening has decreased. The risk of this is a risk 0, no. It's usually, when you get this, it's usually asymptomatic. Lots of people have CMV and they don't know it. If you do have symptoms, they're very general. Fever, malaise, sore throat, and then in a percentage of cases, splenomegaly. If your patient has HIV, they have AIDS, you'll also see a pneumonitis, encephalitis, colitis, and retinitis. So if you have congenital cytomegalovirus, first of all, the mother will be positive for CMV immunoglobulin G. There will be what's called intrauterine fetal growth restriction. So the kid is, IUGR. Intrauterine fetal growth restriction. The child is small for his or her age. There's also usually hydrocephalus. Usually microcephaly, the head's very small. The virus infects the fetal tissue, it lyses cells, and that's what's responsible for a lot of the organ damage. Usually there's hepatosplenomegaly. There's usually also intracranial calcification. And then usually the amount of amniotic fluid that's made is too much or too little. So you have so-called polyhydramnios, or you might have oligohydramnios. If someone has CMV, a biopsy usually will show cells with really big nuclei. And that's what gives the virus its name, cytomegalovirus. So your lab tests, there's very good serology for this. The disease is usually self-limiting, but you can treat usually with goncyclovir, or that will be intravenous, or you can treat with oral valganciclovir. Again, that's oral. There's also cytomegalovirus immunoglobulin you can give. That will usually help treat it as well. And that is cytomegalovirus pretty much. So babies born with cytomegalovirus, they don't reach their developmental milestones. They have hearing, speech, and mobility and language deficits. Vaccines are not available for cytomegalovirus. And there we are.